So, welcome to the videos of endometriosis. Today, we're going to study the last part of endometriosis, and this class is about the classification. Sorry, the classification of endometriosis. Okay, guys, I'm writing everything in detail so that you can make notes out of it. If you feel these videos are little lengthy, so you can make it into a little fast so that videos can be revised fastly. But if you're making notes, make it one into so that you can write the notes in detail. That is the reason why I'm writing everything and explaining everything, and the topic which is very important for your university, NEET, PG, and everything. Nowadays, endometriosis is a hot topic in the gynecology. Okay. Now, what are the classifications of the endometriosis? So, in the endometriosis, there are few societies where they have classified the endometriosis based on the severity, and one is ASRM. You must have seen this ASRM everywhere. This is nothing but called as American. This is American Society. It's an American Society for Reproductive Medicine. Okay, it's called as ASRM. Okay, so now it is revised into it's revised into another thing called as RAFS. That is revised. It's a revised. Okay, so this AFS is American. F is for fertility. This society. Okay, so now what is this society telling about, or what is ASRM telling about, is basically after doing a laparoscopy, you can see the lesions. So on visual inspection of the lesions, sorry, visual inspection of lesions. So now, for example, what we are doing is we'll introduce a trocar as well as the scope, and after seeing that, the lesions which is present on the uterus or on the broad ligament or on the peritoneum, based on the direct visualization of the lesions, they are classifying this endometriosis. Okay, so on what structures, especially this RAFS society is classified based on what structures? Only few structures they have taken into consideration. That is, first is, of course, everyone knows that I have been telling in previous video, that is peritoneum. Next is ovaries. Next is fallopian tubes, and of course pouch of Douglas. So these are the four structures they have taken into consideration. Based on these four structures, the location of the endometriosis, how is it, how extensive it is, they have classified this. Okay, and now this was done in a little late, that is about in 1997. You don't need to remember this year, but recently what has come is 2005. There is a Enzian staging system. Okay, Enzian staging system. Okay, this engine system, in this what happens, they have added retroperitoneal structures as well. Retroperitoneal. They've added retroperitoneal structures. Basically, in a one word, if I want to explain about the enzyme system, is basically it will explain about all the lesions throughout our body. That means it is an extended portion of RFAs. Okay, so RAFS is the society where it is explaining about the lesions which is present only in the peritoneum, ovaries, fallopian tube, and pouch of Douglas. But Enzian is telling along with those the other structures as well, retroperitoneal structure as well. So it is much more in detail. The information is more in this. Okay, this is one more society, and third society is EFI. What is EFI? EFI is endometriosis fertility index. So this index explains the chances, the percentage of conception or the fertility. Okay, so this has come recently, that is 2010. So to predict the pregnancy rate, pregnancy rate in endometriosis. Okay, so this is about the different type of classifications. So this is the image that they have asked in your NEET SS. So what is the society which is explaining about this lesion is about the endometriosis. Here the what are the things that you have to remember is these four things. Okay, so stage 1, stage 2, stage 3, stage 4. So this was the first classification, that is American Society for Reproductive Medicine. That is what I was telling you. That is what I was telling you here. American Society, ASRM. The same thing here. This is ASRM. This is the ASRM, and you have to know how this looks like. So in this, what they have taken is, I have told you peritoneum, ovary, as well as the tube, fallopian tube they have taken. So in this, they have classified based on the flimsy adhesions or dense adhesions on the right side, left side, and the right side, left side. So on the right side, left side. So endometriosis on the peritoneum, superficial or deep. So based on this, what they'll give is, they'll give the numbers, how deep is it, and is it involved only on the right side, only on the left side, or both the sides, whether it is superficial lesion or it's a deep lesions. So based on everything, whether they based on the additions, everything, they will calculate the entire values, and then they have classified into stage 1, 2, 3 and 4. Stage 1 is minimal endometriosis. It's minimal endometriosis. What is the value? It is about to 1 to 5 points. Stage 2 is mild endometriosis. Here the value is about 16 to 15 points. Stage 3 is a moderate endometriosis. Here it's a moderate endometriosis. It includes 16 to 40 points. And it is, of course, fourth one is very severe, more than 40 points. You understood? So this is a ASRM classification of the endometriosis of peritoneum, ovaries and the tubes based on the location, based on the site, based on this everything they have classified, and they have given the values. Based on the values, they have classified into mild, moderate, severe as well as the minimal. So you understood, this is one type of classification. So now next we are going is the enzyme classification. In enzyme classification, I have told you it is little more extensive. So it is the extended part of ASRM, American Society of Reproductive Medicine. So that classification, if you extend it a little more and if you add many more structures, then it's nothing but called as enzyme classification. Okay. So the enzyme classification. In enzyme classification, there is something called POT, A, B, C, F. In F, again the further they have classified into F, A, B, U, I and O. Okay. P, it's very easy, peritoneum. O for ovary, fallopian tube, and A is not like there is A doesn't indicate anything, so you have to write, you have to remember A it as rectovaginal space, important. And B is for the uterosacral ligaments. C is for the rectum. F is for fast structures. Actually, fast structures. In fast structures also, A it includes adenomyosis. That means endometriosis which is happening in the myometrium. B is for the, of course, bladder. U is for the ureters. And I is for the intestinal. So intestinal structures. O is for the other extragenital lesions. These are important. So this is about the enzyme classification. So this enzyme classification is very important. So in this enzyme classification also, if you observe this POT ABC, here they have again classified P1, P2, P3 based on the size of the endometriosis. So the critical, this was the MCQ they have asked. Okay, what is the critical value, or based on the what number you have to do a surgery. Okay, so that is very important. So the critical limit for organ preserving surgery. So this is, it's an MCQ they have asked, that is more than 7 centimeter. If it's more than 7 centimeter, generally the preserving of the structure is quite difficult and it is not even advisable. Okay, that is about the enzyme classification, that's about the ASRM classification. Okay, and next one is you have to just know the image of it. I'll show you the image of the another classification, that is EFI. I've already told you, that is fertility index, endometriosis fertility index. This EFI, how does it look like? So this is how it looks like, the endometriosis fertility index. So here the score they've given us 4, 3, 2, 1, 0. That is 4 is normal, 3 is mild dysfunction, 2 is moderate dysfunction, 1 is severe dysfunction, 0 is absent or non-functional. So what is that? These numbers are given like for this fallopian tube, fimbriae and the ovary on the left side and on the right side. So as the number decreases, the severity is more in the case of EFI. Okay, so in this, what are the things they're taking? So historical factors, that includes age, if the age is less than 35, age 36 to 39, age more than 40. So for that, they have, age more than 40 is 0. If years of infertility is more than 3 years, it is 0. So based on this, if you see this table, you can, it is self-explanatory. So based on all this, they have classified 4, 3, 2, 1, 0. So the 0 is having the worst prognosis. Worst prognosis matlab the infertility is very high, so they have to go for some of the some of the conditions like in vitro fertilization or ICSI or surrogacy or adoption. So that is how you have to take. So severe form of infertility can be seen in the case of 0. So if you just know this image and if you can assess, okay, so this is how the EFI looks like, that is more than enough. So then there is nothing more to study in detail about this. And the questions were also not asked much. Actually, the questions were asked. What are the questions were asked in the exam, in the NEET as also? I'll tell you. What are those? So this was the image where, guys, I'll tell you this image. This one box as filled with MCQs. So there are a lot of MCQs in this. So what are the things they have asked is, first question they have asked in the NEET PG as well and the NEET SS. Here the NEET SS questions are more. NEET PG also they have asked. So in next NEET PG also they might ask this questions more. So what are the first question is, which is the easiest classification? Easiest classification of endometriosis. So that is ASRM. Important. So it's the easiest way of using the classification. And which classification gives the complete description of the deep infiltrating endometriosis? That means I've told you ASRM gives only about the peritoneum, ovary, tube as well as the pouch of Douglas. But whereas Enzian gives about the far lesions as well. It gives about the intestine lesions. It gives about the urinary bladder, ureter, everything. So here we have discussed. So see, it is explaining about the rectovaginal, uterosacral, rectum, fast access like adenomyosis, bladder, ureter, everything this enzyme classification is explaining. So that is what they have told here. See, FA, FB, FI, FU. So all this are involved in the enzyme classification. So it is extensive. So if they ask about the complete description of the deep infiltrating endometriosis, you have to you have to answer it as enzyme. Now, what is the index, or what is the society which is giving a complete description about the fertility predictability? Is EFI. That is EFI. Okay, so now what are the limitations of all this is, first and foremost, ASRM. So it doesn't explain about the deep infiltrating lesions, as well as not only deep infiltrating, even the far lesions also it cannot explain. Okay, so now this enzyme classification, of course, it is giving about the in detailed description about the distant lesions as well as the infiltrating lesions, everything. But the biggest disadvantage is it's not telling about the reproductive index. That means it cannot tell about the outcome, the reproductive outcome of this. Okay, so now what is the biggest disadvantage of EFI? See, in the EFI, if you see, they have taken about the history, they have taken about the age, they have taken about the years of infertility, the prior pregnancy, they have taken all these things they have taken, but they have not taken the lesions which causes the distortion of the uterine cavity, which is very important for the infertility. So it doesn't consider about the uterine abnormalities. So that is the one of the very important thing, that is the limitation of this EFI. This was the question asked in the NEET SS. Okay, so prognostic value, no correlation with the symptoms, quality of life as well as infertility outcome with this treatment. Poor correlation with the symptoms and quality of life and infertility outcome with treatment. Predicts fertility outcomes with the woman with the previous surgical stages of endometriosis, but no correlation with the pain symptoms. So the first two will tell about the lesions as well as the synchronicity with the symptoms, but here it doesn't explain about the lesions as well as the pain and symptoms, only about the infertility or the predictability of the pregnancy. So this one box gives a lot of MCQs. This is the box where the MCQs are asked, whereas this box, it's just an image. So based on the image you should identify which type of society or which type of staging they are doing, that is EFI. And this, of course, I think by this time people were pro in it. Now people can tell what this is, and then classification. ASRM, of course, only peritoneum, ovarian tube, if it is there, left, right, deep, infiltrating, that is all it is present, that is ASRM. Okay, so this classifications they have asked in the NEET a lot of times. Of course, even for university exam also this is very important. That is why I have told you the staging system little in detail. And of course with this I'll end up with the classifications, and next we'll go with the very important topic, that is the treatment part. That is the treatment of endometriosis. Okay, now see guys, I want to tell you one thing. In obstetrics and gynecology, whatever it is, if you know the pathology, the treatment is the easiest part of any lesions. Okay, of course I think this will even match even for the surgery medicine as well. So you should know the pathology. If you know the pathology, of course the treatment is very easy. Now tell me, first and foremost, a patient is there, a female is there. So this female doesn't have any symptoms. Accidentally you identified the patient is having endometriosis. For example, if you are doing cesarean section, so during my residency or when I was doing my fellowships, I've seen a lot of patients who went cesarean section had a lot of endometriosis on the posterior side of the uterus and even on the broad ligament. Sometimes during tubal ligations also I could see a lot of endometric lesions. So now this patient doesn't have any symptoms as such for endometriosis. Will you treat this patient? No. Such patients you have to give expectant management. So no symptoms, no or mild symptoms. So you no need to give any treatment for this, only expectant management. Okay, and next we'll go for the medical management. Okay, medical management. Guys, in the medical management, what I want to tell you is, remember the pathology of endometriosis is the inflammation. It is a chronic inflammatory conditions which you can see in the case of endometriosis. The inflammatory mediators which is causing pain is prostaglandins. So prostaglandins is the inflammatory mediator. It's a inflammatory mediator. So now, since it's an inflammatory mediator for the endometriosis, what you have to give for the symptoms, for the pain symptoms, you have to give the drugs which inhibits the prostaglandins. Obviously, everyone knows NSAIDs. So this NSAIDs, in this, it is basically a treatment for pain. That's what I want to tell you. So there are COX-2 inhibitors, COX-1 inhibitors, which is preferred COX-1 because COX-2 inhibitors basically COX-1 and COX-2 inhibitors, basically COX-2 inhibitors, on a long term, if you use, generally, remember guys, I'll tell you what is that. So in the long term, if you use, what happens, it leads to a cardiovascular complications. So since it leads to cardiovascular complications, the COX-1 inhibitors are preferred treatment for pain management in the case of endometriosis. So in the endometriosis, which is the most common symptom that I told you, is the chronic pelvic pain. They'll have chronic pelvic pain. So the pain can be on the specific sites if the lesions are present. For example, pain over the rectum, pain on the bladder, like bleeding from the rectum, that is hematochezia or hematuria. This is because of the lesion which is present in the particular region. So, but still the pain exists because of the inflammation. For the inflammation, you have to give NSAIDs. So, what is the drug we give? We give ibuprofen. So, what is the dosage? 400 mg thrice daily. Okay. You can also give mefenamic acid. Mefenamic acid also can be given. This mefenamic acid is 500 mg. Even if you don't remember the dosage for this, it's still okay. So you are giving, so generally thrice daily or whatever it is, both are given during the menstruation. Okay, during the menstruation you are giving. You got my point? That's about the pain management. And next, this is about the pain management. In the medical management, first thing, that is NSAIDs. Second thing, of course, combined oral contraceptive pills. So guys, I'll tell you the concept. Just remember, here the pain is there, you are treating the pain. Okay, oral contraceptive pills is basically, for example, you think this is the uterus. Okay, this is the uterus, and this is the endometriotic lesion which is present here. Okay, now what happens, this endometric lesion should be treated medically. So now what happens, you are giving the oral contraceptive pills. This oral contraceptive pills, what happens, it will have the estrogen as well as the progesterone. This estrogen progesterone has a negative feedback on GnRH. Okay, GnRH. And along with this progesterone will also cause decidualization. What is decidualization, guys? Basically, it's a shedding of the endometrium. Like whatever the endometrium is there, that will decrease, it will shrink. That is called as decidualization. So what happens, this progesterone will cause decidualization of all this endometrial tissue. Okay, and vice versa, the GnRH is inhibited. That is why these oral contraceptive pills are given. In MCQs, if they are asking the treatment given for endometriosis, like for example, some drug like oral contraceptive pills, they are given for 2 cycles, or if they are given only for the 1 cycle, or it is given for 3 days, or given for the 1 week, or this NSAIDs are given for 2 weeks. If they are telling you with the weeks, and or if they're giving you the option in years, they'll like 3 years, 4 years, then you should rule out those options. Always the treatment for endometriosis is given in months together, because endometriosis is a chronic inflammatory condition, so you have to give the treatment for months together. Okay, so oral contraceptive pills, how many days? The OC pills, you understood the mechanism of action, what this OC pills are doing. So now OC pills, for how long can you give? These OC pills can be given almost like for the 6 to 12 months. 6 to 12. Now, what is the drug which consists this oral contraceptive pills? What does it includes? Of course, you people know estrogen. And what is that estrogen that consists of? Ethyl estradiol. Ethyl estradiol. What is the dosage? 30 microgram plus levonorgestrel, that is 0.5 mg. So this is oral contraceptive pills that is been given for. Okay, now of course I hope you people remember, I've told you that endometriosis is a hyperestrogenic condition. So this hyperestrogenic condition should be counteracted with the progesterones. So we give even progesterones. Okay, rather we can write as progestins. See, here also uterus, endometriotic lesions. You think this is the progesterone? Progesterone will cause decidualization of all the endometrial tissue. Decidualization of the endometrial tissue. So all the endometrial tissue will decrease in size and it will shed out. So this basically, if you are giving progesterone, you will give it for 9 months. So 9 months progesterone, if you are giving, that means it is nothing but called pseudo pregnancy state. We can tell it like that. So pseudo pregnancy state we are creating. The pseudo pregnancy state you are creating. So what are the drugs we have? Of course, you people must be pro in the progesterone's composition. First is tab medroxy progesterone. Medroxyprogesterone acetate. Okay, so what is the dosage? 20 to 100 mg can be given for 9 months. Okay, next we give tab norethindrone acetate. What is the dosage? Of course, everyone knows 25 to 20 mg. You have to give daily. And third one is dihydrogesterone 10 to 30 mg. See, these doses are very easy to remember. This hydroxyprogesterone, I think everyone knows. So norethindrone as well as dihydrogesterone, even if you remember, you don't remember, doesn't matter. But this is very important. This you should remember. Hydroxyprogesterone acetate. It comes in multiple places. And of course, everyone's favorite, that is DMPA. What is DMPA? Medroxyprogesterone acetate injection. So this injection just given every 3 months. We'll discuss this DMPA injection and oral contraceptives in detail in the contraceptive chapter, but you know that for 3 months we generally give this DMPA. It's actually in the government hospitals and all, they give this DMPA injections as a contraception. Every 3 months we give for almost like for 1 year. So 1 year you give this injection. And now the magic drug, which this is very important, the one which you are using now is Dynogest. This is the recent progesterone, which currently the question they have asked in the MCQ, this important point you have to note, that is the treatment of choice for endometriosis is Dynogest. What is the dose? It's 2 mg daily for, I told you, progesterone 6 to 9 months. This statement please write and highlight as much as possible, because this is an MCQ. This is a question in your Viva. This is a question even for your practice, day-to-day practice. And this was a question that was asked for me during my interview in a hospital. So Dynogest is a magic drug. They are giving it. It is so effective. So this drug is almost it is similar to that of GnRH analogs also. Such good drug as this Dynogest, which has been given. Okay, and of course, next we have is LNG. What is LNG? Levonorgestrel IUCD. This is a IUCD which consists of 52 milligrams and daily. It produces 20 micrograms of progesterone. Just like these are all the non-contraceptive benefits of the IUCD or oral contraceptive pills. These are all the questions. Okay. So this is also very good. And what is the question in LNG IUCD is, the important question they have asked is ESHRA, ESHRA guidelines. I've told you before what is ESHRA also. This ESHRA 2022, they have told it is recommended to use this LNG IUCD. Okay, or if not, LNG we can also use implants. What implants? Subdermal implants, which is made up of etonorgestrol implants, which is kept subdermally, are used. Okay, so this is about the about the progesterones. So this progesterone, you have to remember, medroxyprogesterone acetate, the dosage is important. Okay, the dosage is very important. And for how many days you give? I didn't write here. 9 months pseudo pregnancy state, and of course DMP injection, not so important, but still this is very very important, diagnosed. And this ESTRA guidelines 2022 is telling either IUCD or implants for endometriosis. Understood? And next, GnRH analogs, GnRH antagonist. Okay, so you people know what happens. You think this is the hypothalamus, this is pituitary, this is the ovary. So from here GnRH, from here FSH and LH, from here estrogen. So this is the cycle, and of course progesterone, little amount of progesterone. Now what you are doing, this GnRH analogs that you are giving continuously. So if you are giving GnRH continuously, what happens? This estrogen and progesterone will cause negative feedback on this. Negative. So generally, if you are giving continuously, if you are giving through negative feedback mechanism, this will inhibit the hypothalamus, GnRH production will be reduced, FSH, LH will be reduced, and of course estrogen and progesterone will be reduced. And in fact, continuous production of this GnRH also will inhibit the production of this FSH and as well as the LH. But once you are giving GnRH, what is the biggest disadvantage is initial flare up will be there. Initial flaring up. But here antagonist, what happens? Directly, you think this is the hypothalamus. So this is the pituitary. Now what happens? So this is coming like this, GnRH. So directly this will inhibit this one. So what happens? The biggest disadvantage is the initial flare up. The initial flare up is not there in this. Initial flare up is not there, but initial flare up is there. And since initial flare up is there, it will take time for it to act. So it is slow. So it is fast. Third, it causes, see, you are indirectly, your hypothalamus, you are inhibiting with the analogs, you are indirectly decreasing the estrogen as well as the progesterone. Tell me the condition where the estrogen progesterone is completely reduced in the female body. That is in the case of menopause. So it causes pseudo menopause conditions. Here also it causes pseudo menopause condition. But only thing that you have to remember, as well as the MCQ here they have asked is this MRCOG they have asked, and of course NEET also they have asked, NEET PG. It is dose dependent. It is dose dependent. Okay. Now for both the conditions, you have to give add back therapy. What is add back therapy, guys? Add back therapy is basically, see, when you are giving GnRH analogs or antagonists, what happens? You are indirectly causing them to decrease estrogen as well as the progesterone in the body. So what happens is they will end up like menopause. In menopause, what are the symptoms? What is the severe symptoms in menopause? One is vasomotor symptoms, as well as next is bone mineral density will be reduced. So now to prevent this vasomotor as well as the bone mineral density, what happens? We'll give add back therapy. That means we'll again give estrogen, but that not to such a level where the endometriosis should flare up, but still we'll give estrogen. When we'll give estrogen? For all the cases of analogs as well as antagonists we'll give? Yes, we'll give. But when? even if you give the treatment for more than 6 months, this is important, more than 6 months if you're giving, then you have to give this add back theory. What is the drug that you give in add back theory? Important, make a note of this. Norethistérone acetate 5 mg with conjugated equine estrogen. What is the dose? This is 625 microgram. So this is important. This is the add back therapy they have given. Add back therapy, that means you are giving the estrogen to the body so that the vasomotor symptoms and bone mineral density should not be hampered in a reproductive age group, because endometriosis is a reproductive age group people disorder, right? So that should not happen. That is why we give this add back therapy. You got my voice? Okay. Along with this, of course, the bone mineral density, to prevent that, we also give calcium. We give the calcium. What is the dosage? Everyone knows 1000 mg daily will give as add back therapy. Understood? So what are the other complications of this both GnRH antagonist as well as the GnRH agonist is they will have insomnia, reduced libido, vaginal dryness, headache, everything. So these are the other symptoms of the GnRH agonist as well as the antagonist that causes the complications. Now what are the drugs? First here is leuprolide. Here the dosage is important. Leuprolide, always remember 3.75 mg IM you have to give monthly. Okay, leuprolide as well. All Relin comes. Relin drugs. What are the Relin drugs? Goserelin, Nafarelin, Triptorelin, Goserelin, Nafarelin, Triptorelin. All the Relin drugs. You don't need to remove the dosage. Just remember these are the drugs, but this dosage is important. Leuprolide dosage is very important. And now the drugs which is used as an antagonist is this drug. Now it is blooming up. It is like a drug which is recently many gynecologists are giving these drugs left and right to the patients, and that drug is Elagolix. So this they have asked, but they have not asked directly, but you might get a potential MCQ. This Elagolix, many MRs are also conducting the seminars on this Elagolix, and they are promoting a lot. This Elagolix is a drug that they are using, but of course Elagolix cannot be a main treatment of choice. Main treatment of choice I have told you, Dynogest. So after that, this Elagolix is coming into bloom. Okay, so this Elagolix, what is the dosage? 150 mg per day. That is low dosage. Okay, and high dosage is also there. That is 200 mg per day. So this is the important thing that you have to remember. Okay, next we have is aromatase inhibitors. Guys, aromatase inhibitors is basically what happens. This ovary will convert the androgens into estrogen with the help of the enzyme called aromatase. Okay, not only, even the peripheral tissues also. So estrogen, the fat, example fat, the androgen is converted into estrogen with the help of the aromatase. Now this aromatase will be inhibited. So aromatase inhibitors will inhibit the estrogen. Estrogen also will be reduced. Okay. So now, what are the things that I want to tell you about the aromatase inhibitors are? So in this, of course, I told you the mechanism of action. It decreases the estrogen. So ESHRA, this is a MCQ. They've asked ESHRA 2022 में. They're telling this aromatase inhibitors. What are the aromatase inhibitors that everyone knows on at like tip of fingers? Everyone knows that. What is the drug? Aromatase inhibitors. Come on, guys. Come on, come on, come on, come on. Okay. You will know that. That is letrozole. Okay. Letrozole, what is the dosage? 2.5 mg. For 6 months you give. Of course, letrozole, if it is there, one more drug is anastrozole. That is 2 mg. If you don't remember, that's fine, but letrozole dosage you have to remember. See, letrozole dosage, leuprolide dosage, medroxyprogesterone dosage, dinoges dosage, these dosages are important. They have asked in exam. Okay, so letrozole dosage you have to remember 2.5 mg can be given. So here also this will indirectly inhibit the production of estrogen. The estrogen will cause again menopause like symptoms. So here also you have to give add-back therapy. Add-back therapy you have to give. Along with the add-back therapy, you have to give calcium as well as the vitamin D as well. Vitamin D, how much you give? 400 international units daily you will give. Okay, that's about the aromatase inhibitors. And there's something called as other drug. This is SPRM, that is selective progesterone receptor modulator, the SPRM. Okay, so this SCRM, what is the drug that everyone knows? It's also easy, you must be knowing that ulipristal acetate. Okay, and the drug which you use for MTP, that was also mifepristone. It's also called as RU486. So these are the drugs that we give. Here you have to remember the mifepristone dosage, that is 10 to 25 mg. For how long we give? You give daily for 6 months. Okay, but this ulipristal acetate and mifepristone is not a proved drug yet to give for endometriosis. It is still under experimental. And of course, the last drug which you have to discuss is androgens. First one is danazol. Guys, this danazol, what does it do is it basically inhibits